Okay, guys, I'm gonna get started. If you haven't met me, I'm Taylor. I'm one of the fifth-year EMIMs. And I'm gonna be talking about EKGs in toxicology today. Maybe. Okay, great. So we're gonna go through an approach to the EKG in the intox or suspected toxic ingestion patient, some algorithms that you can use on shift, and then we're gonna apply those things to some EKG examples, and then I'll give you guys a nice summary. So first is the approach to the EKG. So Fleur gave you guys a nice 6-step process for the EKG in the syncope patient. Now I'm going to confuse you with another 6-step process that's slightly different for the tox patient. So first 3 things, you're going to look at rate and rhythm, which I feel like everyone should know. That's our first step on every EKG. And then we're going to look at the PR interval to see if there's any degree of heart block. And then we're going to look at the QRS duration specifically in lead 2. That's just thought to be the best place to manually measure it in tox. And remember that in tox, we're not thinking about a QRS more than 120, we're thinking about a QRS more than 100. So we have a lower threshold for QRS prolongation. And then the next 3 steps, we're gonna look for right axis deviation. Lots of people know to look for a terminal R wave in AVR, but you wanna just think in general about right axis deviation. So for a refresher, that's when your QRS axis is greater than positive 90. So you're looking for a positive QRS in your inferior leads, 2, 3, and AVF, and a negative QRS in your lead 1. So just remember that when we get to some examples. And then also remember to compare, if you have pre-poisoning EKGs available, it can be helpful to compare to see if they have baseline right axis deviation or not. Then you're gonna look at the QT interval, and notice I say QT, not QTC, because especially in tox patients, we're not looking at the calculated QTC interval on the EKG. We're calculating our own QT interval. And we'll talk a little bit more about the risk of torsades in tox patients as we go a little further. And then lastly, you're gonna look for any evidence of ectopy, automaticity, and or ischemia to help you point towards a specific agent. So I'm gonna now put up 3 algorithms. They're from a paper that I'll show you. They're a little overwhelming, but I think they're useful on shift. So it's based on your rate and rhythm. So these are some, let me move that. Some medications that you'll see sinus rhythm with some subtle EKG changes, or if you notice, they also put up just some clinical findings. So if your patient has normal sinus rhythm, they're neither bradycardic or tachycardic. These are some things to consider. Next is bradycardia. So again, it focuses mostly on you have a bradycardic patient, some EKG changes, other things are clinical findings that can help you consider what agents they may have ingested. And then finally, tachycardia based on your QRS and your intervals, and then going down from there. These are all from this paper in 2012. It goes into a lot of detail, but I think it's really helpful to I'm pretty sure I got it for free. Just to look at those algorithms if you have a patient that you know they took an ingestion or you have a suspicion and you want to kind of work through it that way. So now we're going to apply this 6-step algorithm that I mentioned on the first couple of slides. If you were using this clinically and you wanted to kind of use the algorithms, that you would use them in step 1. Otherwise, we're going to do this 6-step process for some EKGs and then talk about the cardiotoxic medications. So audience participation is required. Could I get a junior to give me the rate and rhythm of this EKG? 56, okay. 56 to 60. Okay, so bradycardic, keep it simple. And what is the rhythm? Sinus, right? Okay, great. So Shane said sinus, bradycardia. Next is our PR interval. It's kind of hard. I'll give you that it's hard to read PR intervals on this screen. Okay, so it's a little long, right? The big boxes are kind of hard to see on here, but it is longer than one big box. So this PR interval is 240 milliseconds. In the interest of time, I will tell you those are the 2 abnormalities on this EKG. So it's sinus bradycardia with a 1st-degree AV block. Before I tell you what caused this, I'm going to just show you another one. So if the patient took more of the medication, they would get this EKG, which I'm going to interpret for you. This is a slow junctional rhythm, so still bradycardic, but you'll notice no P waves. The QRS complexes are narrow. Obviously, we can't calculate a PR interval because there's no P wave. But then I am going to ask a junior to interpret this EKG for me, which is if they took even more of the medication. And you can either holistically interpret it or you can go down my rate, rhythm, etc., whatever you prefer. Great. So complete heart block. Our P waves here are occurring at a rate about 90 beats per minute, but our QRS are much slower and they're not related. This also happens to have this like escape rhythm, or the QRS beats are in a right bundle branch morphology, which can happen with this ingestion. Does anyone want to guess what class of medications this is? What? Perfect. Beta blockers and calcium channel blockers. So these are a common cardiotoxic medication. The classic parts of it are conduction blockades, starting with early PR prolongation. They have a narrow QRS unless you have that slow, the junctional escape that might be wide. And it's important that if you see evidence of sodium channel blockade, you should think about propranolol, or conversely, if you know they took propranolol, it can also cause some sodium channel blockade. The most important part of thinking about calcium channel and beta blocker toxicity is that the toxicity progresses. So the more you take, the more conduction blockade you get. So shout out to Dr. Kendall for suggesting this wonderful little animation. So think about it this way. You're blocking the beta or calcium channels at the SA node. The more you take, it just moves down the ventricle. So the more they take, the more of your conduction system is going to be blocked. Okay, so it's a great way to think about that. Any questions about beta blockers or calcium channel blockers?
The dosage of toxicity, for example, so like how much do you take to get to this point?
I do not. That's a great question. Paul was asking if I knew the dose, if it was a dose dependent response, like what the dose was. And I don't. Yeah, I think it would just depend on the patient as well. Sometimes people take both at the same time if they happen to have calcium and beta blockers available. Okay, next one. So can I have a junior do rate and rhythm on this one for me? Or start with rate. Okay. $90. Okay, good. So normal rate. Yeah, so this does not have any P waves. You are correct. So it's not sinus, right? Something else. What do you guys think? So we can't calculate the PR interval. So now we're going to go to the QRS. What do you guys think about the QRS here or here? Okay. Yeah, so it looks maybe a little wide, borderline. I'm going to skip right axis deviation and you're going to look at the QT interval. So what do you guys think about this QT interval compared to the RR interval? Do you think normal, long, or short? Short? Okay, good. Anyone have any idea what medication this is? And I direct you to the ST segment shape. This may be a clue. Perfect. But is this someone who took way too much digoxin? Good. This is called digoxin effect. This is a person taking digoxin. So if you see this EKG, it looks like not normal. But this person is just on digoxin. These are the characteristics of someone who takes digoxin and the things that digoxin causes at baseline. So they have an increased vagal tone, which can cause the, if they have a P wave, they'll have PR prolongation. They get this characteristic Salvador Dali sagging ST depression. Their T waves can do whatever they want. And they do have a shortened QT interval. There's many other findings, But the most important thing we all think about is the sagging Salvador Dali. So now we're going to look at the EKG of someone who took too much digoxin. So what's the rate on this one? Fast, great, tachycardia. And the patient who takes too much digoxin has tachycardia because they have an increased amount of automaticity, because they have increased intracellular calcium. And then what about the QRS duration? I guess think here in lead 2. Wide, great. So they have, it's kind of an interesting combination. So they have a supraventricular tachycardia because of that increased automaticity, and then they have a slow ventricular response because they have decreased AV conduction due to the vagal effects. So in the digoxin effect, you saw they had a mild PR prolongation from the vagal tone, but here it's much more severe. I think about digoxin the same. There's like something in every category that fits this, like syphilis does whatever it wants, digoxin does whatever it wants, hyperkalemia does whatever it wants. That's what digoxin does. So those two things are the hallmark, but you can just get any kind of supraventricular tachyarrhythmia. You can get, this here is called bidirectional VTAC, which I think is the coolest looking one. You can get frequent PVCs, sinus bradycardia, slow AFib, any type of AV block you want. Something called regularized A flutter, which is A flutter with a complete heart block, and then any type of VTAC. So I don't think you need to be able to look at the EKG and say, oh my goodness, this is digoxin. But if a patient who's on digoxin and you see any of these EKG abnormalities, you need to think they might be having digoxin toxicity. So to summarize, they have increased automaticity, but decreased AV conduction. So that leads to a slow ventricular response. And the most common thing you actually see with digoxin toxicity is just frequent PVCs. So you do have to have a high index of suspicion if you know the person is supposed to be on digoxin. Any questions? Okay. Newcomers, come to the front. Come here. I'm going to ask you questions. I can't, they've been here already. So you guys have to come down here so you can interpret some EKGs. Okay, good. This is the next one. Another category. I'll let you guys get settled before I ask you. Can someone tell me the rate? Fast, great. Rhythm. Okay. Yeah, there might be some P's and the T's, but we're not really sure. So maybe sinus, maybe not, definitely tachycardic. Because we can't exactly see the P's, we'll skip PR interval. Next, we're going to do QRS duration in lead 2. Wide, great. Next is right axis deviation. So we're going to look at, where did I say it has to be positive? Inferior, right? So positive here, and then where is it going to be negative if we have right axis deviation? 1, negative, great. And then, so we have right axis deviation. We're going to look at our AVR to see if we have a terminal R wave. Do we have a terminal R wave? Yeah, great. So what is this? Great, this is TCAs, or more generally, sodium channel blockade. TCAs are very promiscuous medications, so they affect multiple receptors. But the things that we just went over are characteristics of their sodium channel blockade. The parts that are characteristics of other blockade, so the tachycardia comes from the muscarinic receptor blockade, and they can actually have QT prolongation because of inhibition of potassium channels. They also can just directly cause myocardial depression, so you may see ST changes from that as well. And this is where our QRS is wide, but even if it weren't very obviously wide, we would want to measure it, because if it's above 100, we have an increased risk of seizures. And if it's above 160, that's an increased risk of ventricular tachyarrhythmias. So this is the sodium channel blockade, is where you really want to measure your QRS and have a low threshold to treat. What do we treat this QRS widening with? Right. All right, so this is just a really cool, unique EKG. So this is a massive carbamazepine overdose. In massive doses, carbamazepine causes fast sodium channel blockade. And so they can have an EKG very similar to a TCA. The QRS widening tends to be more subtle, so they're closer to that 100. And they have less commonly have the terminal R wave. So you kind of have to have a high index of suspicion for this, but I just thought it was really interesting that it's a slightly different EKG, but still you'll see features of sodium channel blockade. So this is a non-exhaustive list of all the medications that cause sodium channel blockade. We all think of TCAs, but you also need to think about antimalarials, antiarrhythmics, local anesthetics, and other medications. I mentioned propranolol before, carbamazepine, and quinine. So this is just important if someone's on one of these medications and their EKG looks like this, or you have one half of that, you want to get a good medication history about what's in the house. Yes, yeah. Thank you. Misha mentioned Benadryl as well. Yes, yeah. So you would, because they're all causing sodium channel blockade, you would treat all of them with sodium bicarb. So you treat them like a TCA. And it's just a reminder that if you have, yeah, guys, come down. Come. You're not interrupting me if you come down. Thank you. What an entrance, Natasha. And it's important because all of these cause sodium blockade that if the QRS is above 100, like if you talk to the poison center and you have an ingestion and you don't know what it is, and the QRS is 100 or above, they're going to tell you give bicarb. Because this is something that you don't want them to start seizing or get more prolonged and have a ventricular arrhythmia. Okay, so now the rest of the EKGs are for the newcomers. So can someone who just arrived tell me the rate and rhythm of this EKG? Yeah, I told everyone it's audience participation because otherwise this is boring for me. Anyone? Rate and rhythm? Slow, great, okay. Okay, great. For time, we're gonna focus specifically on intervals. So can someone look at the PR interval and tell me normal, short, long? Short, okay. And the QRS duration, and we look, for those who just came, we look in lead 2, narrow or wide? Narrow, okay. And then the QT interval, a little long. Great. So this EKG is showing sinus bradycardia with QT prolongation. And if you hadn't caught that, it turns into this. So our fear with all QT prolonging medications is torsade. So that's why we focus so much on the QT. And then this is another interesting one. So can someone tell me the rate and rhythm? Fast, good. Tachycardic, rhythm, regular, P waves, good. So we have sinus tachycardia. We're in the same theme, so let's do PR interval. Short, okay. And then QRS duration in lead 2, narrow, and then QT. And you can look at the QT in any lead you want. So I think on this EKG, it's a little easier, like V2 is just set up really nicely where you can measure from the Q here and then the T ends maybe there. A little long. So this is interesting. This is quetiapine toxicity. So quetiapine causes a brisk sinus tachycardia as well as a prolonged QT interval. But quetiapine has a relatively low risk of torsade as compared to other QT prolonging medications. And similar patterns can also be seen with other atypical antipsychotics. So we all have this issue where we're like, their QT is long. Can I give them these QT prolonging medications? Are they going to go into torsades while I'm taking care of them? So this is our main fear with all of our QT prolonging medications. So there are 2 ways that you can assess the risk of torsades and this is specifically in a tox patient. You can use the nomogram, and this is where you take the absolute QT. So this is you measuring it yourself, not looking at what the computer says. Then you take the heart rate on that same EKG. And if they are above the line, they are considered to have an increased risk of torsade. And as you can see, the risk changes with the heart rate. So meds that cause bradycardia have an increased risk of torsades because those go together as an increased risk, whereas the tachycardia is kind of like a protective benefit. That's why medications like quetiapine have a lower risk of torsades. It doesn't mean the patient's not going to go into torsades. It just means it's a lower risk. And if you don't feel like plotting a graph while you're on shift. You can try the route to Harju method. This is a study that came out 3 years ago. It has not been externally validated from anywhere I could find, but it's a method that was compared to some of the more traditional like cardiology methods of calculating QTC. And they found that if your route to Harju QTC is more than 477, you have an increased risk of torsade. Obviously, you can see it's the QT related to the heart rate, and then they have a coefficient there. The moral of the story of these two slides is do not look at the QTC on the EKG. In tox patients, you need to look at the QT yourself and think about the heart rate. So whichever method you choose, or maybe another method in the future will come out. ACEP says use one of these, but they don't really have an opinion as to which one. Just don't use the QTC, do it yourself. So this is a list, again, non-exhaustive list of QT prolonging medications, just highlighting the big categories. So antipsychotics, we talked about the atypicals tend to have that protective sinus tachycardia, so they have less torsade risk. Your antiarrhythmics, procainamide, flecainide, amiodarone, antidepressants, including TCAs, because remember that they're very promiscuous, escitalopram, venlafaxine, and bupropion. Antihistamines, we mentioned diphenhydramine, and also loratadine, which I thought was really interesting. And then other medications like hydroxychloroquine, chloroquine, the macrolides, and methadone. So it's a lot of medications to consider, and that's why it's an important thing to look for. So just to summarize, QT prolonging medications, you're looking for an absolute QT more than 500. It occurs due to blockade of the potassium efflux during repolarization. The increased risk of torsades occurs with low heart rate, and make sure that you calculate your own QTC or use a nomogram. I don't have questions about QT prolonging medications.
Based on the nomogram, to me, it looks like lower heart rate requires a higher QT interval, but also because you have a lower heart rate, QT is just bound to be
exactly
when not correct.
Correct.
So this is taking that into account even with this.
Correct. So Paul is asking because it looks like on the nomogram that if you have a lower heart rate, like if you look at a heart rate of 40, there appears to be a higher threshold, but it's actually because this is not the QTC. So this is not corrected for heart rate. So that's why it's really important. If you're going to use this, you have to do your own QT. If it already accounts for heart rate, then this relationship doesn't work. Thank you. Okay. So these are our conclusions. So make sure if you use the approach that I have, which is from Life in the Fast Lane, or another one, make sure you use a systematic approach when evaluating EKGs, specifically in the tox patient. If you have a patient who took beta blockers or calcium channel blockers, they're going to have a narrow QRS with conduction blockade. To jot in, remember, increased automaticity and slow ventricular. They have anything from PVCs to bidirectional VTAC. And Salvador Dali just means they're taking their meds as prescribed. Sodium channel blockade is a terminal R wave, and they tend to have sinus tachycardia. And QT prolongation, the risk of torsades increases with low heart rate. These are my references. Like 90% of that is from Life in the Fast Lane or the Internet Book of Critical Care. So if you don't use those, I recommend them both.